Hi, everyone. This is A. David Crawford, Editor-in-Chief of Grand Rounds in Urology. Joining me from the University of Cincinnati is Dr. Abhi Sidana. Abhi is a urologic surgeon who has done a lot of work in the area of targeted focal therapy and imaging. Ali rather trained at the Institute of Medical Sciences in New Delhi. He did a fellowship at Johns Hopkins, where he did a lot of research on cryoimmunotherapy, and then came to University of Cincinnati Medical Center, did his training there, and is on staff, and we're happy to have him join us to talk about this. I was talking to him earlier. I did my training at the University of Cincinnati, and it's great to have a fellow Ohio Buckeye on with me. So, Avi, thanks very much, and we look forward to hearing your talk on focal therapy.
Thank you, Dr. Crawford, for the kind introduction. And thank you for giving me an opportunity to present on the rationale for focal therapy of prostate cancer. In next 15 minutes, I will try to make a case for focal therapy of prostate cancer and make a case so that this is a treatment strategy which can be adopted between the two extreme options which we currently have: radical whole gland treatments and active surveillance of prostate cancer. So what is focal therapy for prostate cancer? It is a treatment that aims to eradicate significant cancer in the prostate and preserve the benign tissue. By preserving prostate tissue, the hope is that we'll be able to preserve genitourinary function in terms of erections and in terms of urination. So I'm going to highlight these three key points which will make a case for the rationale for focal therapy. The first point is, first and foremost, currently our treatment strategy involves only dichotomous options. We have a radical whole gland treatment which induces a lot of morbidity and harm to the men who undergo these treatments, and the other extreme is no treatment at all. And men who are on active surveillance have anxiety, and a lot of them progress or change their mind and undergo whole gland treatment. The second is, over the last several decades, we have learned more about prostate cancer biology, and we have not tailored our treatment based upon biology. We're trying to adopt a treatment strategy where one size fits all, and that's probably not a wise option for prostate cancer. Over the last 2 decades, prostate cancer has also become visible. With prostate MRI, now we can see prostate cancer, so we can find prostate cancer and treat it and not have to treat the benign tissue because we can localize prostate cancer more accurately. So starting with the first point, in the current status of prostate cancer, we have 190,000 cases every year in the United States. Greater than 30% of cases are low risk. Another 30% are intermediate risk prostate cancer. Both of these categories have very low risk of prostate cancer mortality. Still, majority of patients receive definitive therapy. The definitive therapy in terms of whole gland treatment induces a lot of morbidity, impairs the quality of life in these patients in terms of sexual, bowel, and urinary function. There are 3 trials evaluating radical treatment versus observation or active surveillance in prostate cancer men. The first was a Scandinavian trial, which showed radical treatment reduces disease-specific mortality, but there was no advantage in terms of overall survival. Then Pivot trial ran in veteran affairs population in the United States, did not show any reduction in the disease or all-cause mortality. There's a trial ongoing in UK called Protect trial, and mortality from prostate cancer was low in this trial among all 3 arms: radical surgery, radical radiation therapy, and active surveillance. However, men on active surveillance had a higher odds of getting metastatic disease during follow-up, but there was no survival difference even at 10 years. So while the radical treatment has not made men live longer. One thing it has guaranteed is side effects. Men who undergo surgery in PROTECT trial were found to have more erectile dysfunction than men on active surveillance. They were incontinent more often, and both of those dysfunction persisted through the study period. So we're treating men with radical treatments for a disease which is most likely not going to kill them. And during the process, we're inducing a lot of side effects. On the other hand, we can't put all men on active surveillance. That would not be feasible. In this multi-institutional cohort of men, at 5 years, only 56% of men were still on active surveillance. 44% of men drop out of active surveillance. Either their disease progressed or they got anxious and opted for treatment. And this is a carefully selected cohort. So this further emphasized that we cannot adopt a strategy where one size fits all is a good option. That's where the prostate cancer treatment needs to evolve. It needs to evolve on the lines of breast cancer management. In breast cancer, when the breast cancer management in 60s was started, it involved Halsted radical mastectomy, where breast tissue, lymph node tissue, and chest wall muscles were removed. Then surgeons realized that removing chest wall muscles were not contributing to oncological efficacy, and they were spared with the new modification of the mastectomy. But more recently, women are undergoing only lumpectomy and adjuvant radiation without compromising oncological efficacy and still preserving the function. Organ sparing is not unique in breast cancer. Their organ sparing is seen in kidney cancer with partial nephrectomy, TURBT in bladder cancer, partial penectomy. In all those cases, without compromising oncological efficacy and preserving maximal function. And that's where we need to go in prostate cancer. Now, coming to the second point about prostate cancer biology, we're talking about focal therapy, but prostate cancer is inherently multifocal. It doesn't seem very intuitive. And that takes us to index lesion theory. While prostate cancer is multifocal, there is a hypothesis that there's an index lesion, which is the largest lesion in the prostate, which drives the biology and determines the prognosis for these patients. So this lesion contains the highest tumor Gleason's grade, highest stage, and highest volume. And if we can identify this lesion with precision and target it and destroy it, potentially we can achieve an oncological efficacy of whole gland treatment. In this study done at University College of London by Dr. Ahmed's group, they looked at 100 consecutive whole gland specimens from patients undergoing radical prostatectomy. They defined their index lesion as the largest focus of prostate cancer. What they found was in their patients, each one of them had a single index lesion, but several secondary lesions. But majority of the secondary lesions were less than 0.5 ml in volume, and majority of them were Gleason 6s. Invariably, the tumor volume, Gleason score, and pathological stage was determined by the index lesion in the specimen. Secondary lesions had no impact on the pathological stage or overall Gleason score in these men. And they determined that 50% of their men would have been eligible for focal therapy. There's more evidence for this theory from the lab work done at University of Chicago. This study by Vanderbilt et al. Tried to evaluate the pathological mutation in different prostate cancer foci. They found that the low-risk prostate cancer did not share any significant mutations with high-risk prostate cancer. But the high-risk prostate cancer shared a lot of mutations from the metastatic disease. In their model of prostate cancer evaluation, they determine that both low-grade and high-grade prostate cancer arise from a common progenitor cell, and then the high-grade disease further gives rise to metastatic disease. The low-grade disease does not convert to high-grade and gives rise to metastatic disease, further providing evidence that it's the high-grade disease which impacts the prognosis in prostate cancer patients and not the low-grade disease. As another study done at Johns Hopkins, the scientists isolated DNA from 94 sites in 30 men who died of metastatic prostate cancer. They did high resolution genome void, single nucleotide polymorphisms, and copy number survey to determine the clonal origin of prostate cancer cells. What they found out was that all the metastatic sites were monoclonal, which means a single cell in the prostate gave rise to all metastatic disease. So if you could identify this cell before it becomes metastatic, potentially you can target it, then probably you can avoid all metastatic disease. And this is what this schematic diagram shows. Prostate has both low-grade focus and high-grade focus, but it's the high-grade focus which gives rise to metastatic disease and cause the prostate cancer mortality. If we can identify this focus before it becomes metastatic, before it spreads disease elsewhere, and we can destroy it, then potentially we can achieve the oncological efficacy of whole gland treatment. And that takes us to the third point. Prostate cancer is now visible. We can identify those high-grade focus preoperatively, and we can localize them well with prostate MRI. Prostate MRI and the combination of target biopsy can accurately delineate the lesion and better risk stratify these patients. There are thousands of studies demonstrating that prostate MRI has very high accuracy in determining index lesions, in determining clinically significant cancer. Several studies have also demonstrated that MRI can identify index lesion accurately. In one of these studies done at NYU, combination of saturation biopsy along with prostate MRI detected index lesion accurately in 96% of the cases. And combined approach detected clinically significant cancer in 97% of the cases. So very high proportion of cases, we can find clinically significant cancer accurately and determine what is cancer and what is not cancer in the prostate. That takes us to our current paradigm. Our current paradigm involves patients presenting with clinical suspicion of prostate cancer, followed by ultrasound-guided biopsy, diagnosis of prostate cancer, and based upon the risk stratification, we offer only two options to the patient: active surveillance or whole gland treatment. But MRI is changing this paradigm. It's shifting this paradigm. Incorporation of MRI at every step and incorporation of MRI fusion biopsy has allowed us to better risk stratify prostate cancer patient. It has allowed us to identify if the disease is low risk, where active surveillance may be more appropriate, whereas a disease might have an index lesion, which can have potential lethal implication and can be ablated, or if the patient has bilateral clinically significant disease treated only by whole gland treatment. It has made prostate cancer care more personalized. In conclusion, prostate cancer diagnostic pathway is changing by incorporation of MRI at each step. MRI has allowed us to better delineate clinically significant cancer from insignificant cancer and from benign prostate tissue, thus allowing us to accurately target these lesions. The dichotomy of treatment options which exist in current status involves a lot of harms of overtreatment and undertreatment involved with prostate cancer management, and it's probably not the ideal way to manage prostate cancer. Prostate cancer treatment needs to be complementary and not mutually exclusive. This treatment needs to be based upon the aggressiveness of prostate cancer, where the low risk can be offered active surveillance, a higher risk isolated lesions could be offered focal therapy, and bilateral clinically significant disease could be offered whole gland treatment. That sort of personalized treatment option is our way forward, and it's an alternative strategy I propose for prostate cancer management. Thank you.
Thank you very much. That was a great presentation. Let me, the whole thing with focal therapy has evolved very slowly. There were a lot of roadblocks, but I think now with some of the interesting data that you presented regarding the index lesion metastases, MRI, and other things like that, my thing about focal therapy, and it's been my sort of way forward since we started it a decade ago, it's been we need to know what the target is. It's pretty easy to ablate. There's lots of different ways to do it. One of the things that's come around in the last couple of years is micro-ultrasound, and I think it's gaining a lot of traction. It looks like MRI is losing some traction here. A couple of recent papers come out on that. So I wonder if you might comment on that in your feeling about the micro-ultrasound and what role that's going to play here.
I have limited experience with micro-ultrasound. I have utilized it in patients where I was not able to obtain prostate MRI. And I guess maybe I'm still in the learning curve of it. And in my hands, the accuracy was not as accurate as prostate MRI in patients where prostate MRI was available. But I heard a lot of evidence. I read a lot of evidence that the efficacy and accuracy might be comparable to prostate MRI in detecting clinically significant cancer. But I think it's very operator dependent, while prostate MRI, I think, has become more objective with pirate scoring and increased experience of radiologists in diagnosing clinically significant cancer.
I mean, there's no question there's a learning curve with everything, including MRI. One of the issues that seems to be emerging with MRI is that it does miss, at least from the UCLA group, 20 to 25% of significant cancers. Does that worry you, or how do you follow these patients to make sure that they don't slip through the cracks?
It does worry me, and I try to get 2 biopsies for my patients, especially if a patient is a referral patient. I repeat their biopsy before making sure they're focal candidates. Then at 6 months, I repeat their MRI, and even if MRI is negative, I repeat their biopsy. And occasionally, we do get some failures, small amount of Gleason 7 out of the field. But with prostate MRI, eventually, if we would have just followed these patients without repeating their biopsy, I believe those lesions would have become visible down the line. I do not think that invisible small Gleason 7s would lead to prostate cancer mortality. I don't think patients die from invisible disease. So ultimately, if we would wait long enough, if this disease was going to become clinically significant and would require treatment, I think probably a prostate MRI would still end up detecting it. They are invisible right now because they're very, very small, but also that means they're less lethal.
A lot of the critics and those that are concerned with targeted focal therapy will say that, well, a lot of these patients really don't need to be treated. They're great candidates for active surveillance. And now we've got some markers that help us determine, add a little bit more dimension with Oncotype and Prolaris and Decipher and other things like that. What are your thoughts about that?
I've been using Oncotype DX and actually in a lot of these patients. And when the risk comes back as low, and I discuss these with patient, Gleason 7 patient, low volume Gleason 7, localized lesion. And I talk to the patient, some of them opt out of focal therapy and stay on active surveillance, while other patients still continue active surveillance, continue on for the focal therapy. And I think that's where focal therapy fits in. So it's not a treatment for Gleason 6 prostate cancer or very low risk disease. It's a treatment where active surveillance might be borderline and patients are anxious and you cannot keep them off operating room table. And I think they would be ideally treated with focal therapy with minimal impact on their sexual and urination compared to radical treatments.
I think you hit that right on the head because dealing with men that are found to have low risk lesions, and we do mapping biopsies, not just MRI, to look for that. Once we know where it is, and we talk to them about, well, this is really low risk, we can follow this one thing after another. And they said, doc, get rid of it. And as you said, most of the time, by the ablative techniques we use, we do really well with our morbidity from the treatment. Listen, thanks a lot for sharing this. You're one of the pioneers in this area with focal therapy, and we appreciate you spending your time with the Grand Rounds audience. And we'll stay in touch, and maybe we can follow up in a year or two and see where we are then. So thanks a lot.
Thank you, Dr. Crawford. I learned a lot from you, and you've been a great inspiration to all of us.
Well, thank you.
Thank you.